All right, you guys back to seeing everything? Cool. All right, so let's start off with the endo failures. Same thing as far as disclosures from last time. I do sometimes work with Son Endo. It's been a minute though, so it's fine. Anyway, they got a new logo, so there you go. So what we're going to talk about today is failures, and it sucks to be a failure. No one likes that term. And so what I recommend we start doing is doing what our medical colleagues do and instead call it a revision. So I had a nose surgery that was done about a year and a half ago to help me breathe better, and the one side didn't take. And every time, no one said it was a failure. No one said it was a retreat. They just said, oh, you're here for your Vivair revision. So also happens to be the name of my favorite brewing company in Reno when I was actually there yesterday picking up beer for our fantasy football draft with the dental group tomorrow. So another good way to use it, but try to think of it more as a revision. And so when we're defining failure, let's go to this, little rag called nature and see what is even the point of what we do. When you do a root canal, why do we even do this in the first place? And it is to prevent or treat apical periodontitis so the tooth can be retained in the oral cavity in healthy conditions. Beautiful. All right. If you have signs or symptoms of disease, that means that apical periodontitis or disease is present. So let's go through a couple of those definitions. I am proud enough to admit that as long as I've been in, I started dental school 15 years ago. No one has ever explained to me the difference between sign and symptom. Does anyone here know the difference between a sign and symptom? Could you tell me?
Symptom is what the patient feels.
You're fantastic. Nice. Who said that?
I did.
Nice.
Great.
I'm proud of you. Very good. Great. Signs are what we can see. That's swelling, that's drainage, that's sinus tracts, things like that. A symptom is what the patient feels. And I was 36 years old when I finally figured this out when I was putting this presentation together, because like, wait, I've never actually known that. So there you go. There's your lesson for the day, if you haven't noticed. So when we kind of look at this, what is that definition and what is apical periodontitis? So when we talk about apical periodontitis, that's what we're all trying to prevent. That's when you look at anything endo, you're going to see the words apical periodontitis. And we've named it a bunch of different things. Pretty much World War II is over and all the dentists were like, yeah, let's just start naming stuff. And you'll see some of the terms that you've seen in the past. So periapical, we have abscess, we have periapical abscess. And finally, in 1950, in stomatologia, we have the term apical periodontitis. So what the heck is it? It is, why is this going up there? Go away. Thank you. Local inflammation of the periapical tissues that originate from pulp disease. And the infected pulp is the main cause of apical periodontitis. So this is going back to the Kakahashi lecture that the work that we saw back in the 1960s. You need bacteria to need a root canal. I don't necessarily agree with all of this, but this is what the big definitions that are put out by NIH, Nature, AA all say. The goal of endo is to stop periapical or apical periodontitis, and AP comes from bacteria and from infections. So when we look at outcomes, there are different ways of measuring it. And the question is, who is measuring it? So we're going to go through all these in more detail. You can have process centered. You can have it centered based off of what the doctor wants. You can have it based off of what it looks like histologically. You can have the radiographic, and that one obviously is very big for us in endo. We take mini snapshot outcomes every time we see a patient and look at the tooth. And then finally, you have patient or value-centered outcomes. Now, process-centered outcome is what you probably all learned in dental school. Did all of you learn in dental school that it's more like a if this, then that? So if you take it to 35, or if you take it to the point where you get clean dental shavings, or if you take it and use this toy, you will have success. Was everyone kind of taught that way in dental school?
Yeah.
Probably. No? Yes?
More or less.
More or less. Okay. And I can show you cases that have a size of 35 and they fail. I can show you a size of no size and it's still working somehow. And I can show you cases where we got everything nice and clean and we use the gentle wave or use the laser and it still fails. And the point is, doesn't matter what you're going after. And is everyone familiar with the term the look? That was big in the 1990s, kind of like the pretty much run through a pro taper series and you'll have the look. Really big taper, nice all the way down to the very bottom. It's usually associated with vertical root fractures. And that is kind of what the people are looking at. As you look at the They want to, if you do this, then you'll have success. And this is so attractive to us as people because we love recipes. If you do this, then this works. And unfortunately, there's nothing I can say. If you take it to X size, you're going to have success. I can tell you, you'll probably be more likely if you do X, Y, or Z. But if you just read these things and read what, a lot of the companies are saying, use this product and you'll get great success, that's not really the case. Here's a good success thing. Does everyone here know how to increase your root canal success rate by 20%? I'll give you a tip right now. What do you guys think? Throw it out there.
Relocate.
Say again?
Relocate. Like to move around.
A geographic success? Yeah. I mean, that's great. I have 100% success of everything I did in residency, obviously. Don't look at the cases. No, it's do the restorative. The only thing that's been shown to make that big of a difference, I mean, using the rubber dam hasn't been shown to make that big of a difference. Use it because it's legally required and you'll get your ass sued off if you don't. Using bleach isn't required. Even getting down to the apex isn't required. What is, though, is you got to seal the top part of the tooth. And the better you do that, there's been multiple studies that have shown the best way to increase the success rate of your root canal is to have the endodontist place the core at the time that they're doing it. So there's a fun fact for the day. Next one is doctor-centered outcomes. And this is the doctor knows best. If you talk to, depending on how old your parents are, but certainly your grandparents, when they went to the dentist, there wasn't a treatment planning conversation. The dentist just said, hey, you need a crown. Let's get it taken care of. And that was how the conversation went. And it's based off the goals of the provider, which sometimes can be evidence-based. Sometimes it's a gut feeling. It can kind of be up in the air. And it's based off of their own metrics. The problem with this is there's no patient autonomy. The patient isn't involved in this conversation, and it's incredibly paternalistic. So I always get glee poking at the other endodontists in town. So this is an office that I used to work at, and they very prominently displayed this case on their website. The blue bars are the patient's name prominently displayed on their website, HIPAA be damned. So that's real fun. And they're showing this as, if you want to know the look, this right here, that case on the right-hand side, that is the look. That's what you're going for when you do a root canal. But when you think about it from a patient standpoint, well, that isn't filled, so they have to go back and get it, another appointment with their general dentist. B, it's hard to see on here, but on my screen, you can see that calculus spot on the distal of 31 is still there. So they still have periodontitis and inflammation in that area. And C, I don't see any signs of infection going on from this tooth in the first place. I obviously don't know what was going on in the first place, but I would suspect this was a case where they had cold sensitivity and we fixed it by doing a root canal. And if we had just maybe done some bite adjustments, it probably would have gone away. And so that leads us to my version. And what I want to say is we all do this. We all have our doctor-centered processes. I think this is a much better root canal from my standpoint because it's better for the patient. It's much more conservative. I can send them back pretty much prepped and ready for a crown. Very different experience, but no matter what you're doing, I think one of the favorite lines I've heard is, patient presents for experimentation. And you're doing a test on every single patient, whether or not you realize it. So it's better to realize it and try to see what works and what doesn't. And yes, I do see the gross decay on 31, and he's coming back for that in a couple weeks. So don't worry, I didn't miss that one. So then we have histological-centered outcomes, which is based off of the histology, meaning that it's free of any inflammation at the apex. And so this is my wife and one of our dogs, Penny. And the reason I put that in there, have you guys done the outcome studies in classic lit that was based off of using beagles? Does that sound familiar?
Yeah.
Yeah. Do you remember the results?
No.
So what they did, yeah, great job. We're a powerhouse when it comes to classic lit, you guys. All of you are going to be clinicians. That's perfect. That's what you need to learn how to do. The point of those studies was they would, create perforations and they'd put amalgam in there and they'd put super EVA and they'd put composite and see what the difference was. And they'd kill the dogs and take out block sections. They look at the teeth histologically. And guess what? It's all fine. And that's because dogs are amazing in their ability to heal. My brother and sister-in-law are both veterinarians up in Portland, and I'm so jealous because they get to work on probably the easiest patients ever because what you do on a dog, you don't have to be perfect. It just works. Whereas we work on people, which is very different. The other thing, the problem with this is how do you measure this? I have a root canal in number 7, and I'm not going to volunteer to have it cut out in giant block sections so we can see if there's any signs of inflammation at the apex. Does anyone want to volunteer for that? I'll do a root canal on you, have a huge chunk cut out just so we can see if there was any inflammation there. No? And then the other question is, does it matter? There are a lot of people who walk around chronically inflamed and a small little spot on their tooth isn't causing them any problems. And we'll get into the problems with that measurement in particular once we go over radiographic ones. So when we think on this, if we think about inflammation, on an x-axis where you have on the far left-hand side is going to be very low inflammation or low activity, and on the right-hand side you have very high inflammation or hyperactivity. And then on the y-axis, that's the morbidity from having a procedure. And when you think about patients who have no immune system, so if they have really bad infection, if they're undergoing AIDS, even though that's not really a thing anymore in the modern day, or at least in the first world countries, you have chemotherapy patients, immunotherapy patients, things like that. Now, all of a sudden, if you have no immune system, that's when we see the huge swelling. That's when we see really bad bacterial effects. On the right-hand side, though, we see the total opposite. You can still have just as many problems if the immune system is hyperinflamed. And this is actually from a epidemiologist who came and talked to the IAE last year about COVID in particular. And the people who died from COVID were on the left-hand side, the really, really sick, those who were undergoing, bone marrow transplants, the elderly. And then on the right-hand side, you also have patients who were obese, chronically inflamed, and both of them died from COVID, but for very different reasons. On the left-hand side, it was from the infection, and on the right-hand side, it was from a hyperinflammation. That's why they used dexamethasone in a lot of these patients, was to tone down the inflammatory state. And so inflammation, we know that if you drill a small little hole onto enamel, you will have an inflammatory response inside, even if you just gently, like if I adjust the bite on enamel, your pulp tissue will have an inflammatory response inside there. Now, does that matter? Probably not. And that's why looking at histological outcomes is so tenuous, because does it really matter is the question. We also have radiographic outcomes. There's my 3-year-old getting her first x-rays at Dr. Kelly's office. So she was very big and brave. And the other question comes, how do we measure that? You have the periapical index, you have a Strindberg criteria. Do we want to look at doing it using PAs? Do we want to use cone beams? Do we want to use even different methodologies? And this all leads us to a concept known as stage migration. Have you guys learned about this? The Cotomy guys should. If you've had John out there, he's probably talked to you about this. Does this sound familiar at all?
It does not.
Okay, cool. So stage migration was originally talked about in cancer outcomes. And this guy over here is Will Rogers, and it's known as the Will Rogers phenomenon. And he, no one knows him because none of you probably know him because he died in the 1930s. But he was a radio personality and TV personality. And he had a quip, which is when the Okies, which was kind of like a derogatory term like hillbilly, when they left Oklahoma for California, they raised the average IQ in both states because they were dumb, but the people in California were even more dumb. And what this is kind of talking about, and what does this mean in cancer, is as you increase your diagnostic imaging power, the staging of the cancer migrates to a higher level, but the survival stays the same. And if you look at our survival rates for something like breast cancer, which is very well studied, it was really, really bad in the 50s. And then we started to get chemotherapy, radiation, better diagnostic, and we saw an increase. And if you look at the survival rates since like 1980s, 1990s, they've stayed about the same. We actually haven't made a dent in cancer outcomes at all. What we have done, though, is now you'll see, we're much better at treating stage 4 cancers than we are at treating than we were in the past. And that's because we're finding them earlier. And imagine going from a PA to a cone beam. You know how big the lesion has to get on a PA for you to see it. On a cone beam, it can be much smaller. And so this is why when you look at outcome studies using cone beams, you're probably going to see a decreased outcome if they're using that same measurement as they were for PAs. Does that make sense to everybody? Did I just confuse all of you? No,
we're following you.
All right. Thanks, Johnny. I appreciate you. Said another way, if you zoom in enough, you will see apical periodontitis. Just as I guarantee, if we zoom in enough, there is a cancer cell in every one of us right now. It's probably being taken care of by our immune system. But if you zoom into the apex of our teeth, there is going to be some inflammation histologically in every single one of us right now. And so the question is, does it matter? And that's a question for all of you to answer. So this brings us to the idea of inflammation and histology. So this was from the AAE's podcast. I listened to this right after the AAE meeting in May, and it's Dr. Ikuchi. I'm sure you guys have read papers by him. He's world-renowned, great histologist. But his thing was you shouldn't do patency because it causes inflammation out the end of the tooth. And that is probably true. If you take a little file and you shove it down into the periodontium, you're going to create some inflammation. But does it matter? And that's the question that histology cannot answer. And that's why a lot of the classic lit and the way that we look at things leaves out the most important part of it, which is the patient. So it's kind of like, he's a histologist. He's incredibly good at that. But you've all heard the analogy of the drunk looking for his keys. Does anyone know that story?
I haven't heard it.
All right, I'll tell you the story. Walk outside a bar, drunk's trying to look around for his keys, and he's looking in the streetlight. The guy comes up, he's like, hey, what are you doing? I can't find my keys. Well, did you lose them in the light? No, I lost them over there, but this is the only place I can see. And that's what we do with a lot of our research is we're only looking at what we can measure and what we can see. And we may be actually missing the much bigger picture in the dark because we cannot look at that. That makes sense? All right. That all leads us to what I think is the most important thing, which is a patient or value-centered outcome. So this has been around. This was October 2013. Another small little rag known as the Harvard Business Review came out with the strategy that will fix healthcare, which states that the core of this type of treatment is maximizing the value for patient. We have to go away from a system organized around what patients do and toward a patient-centered system based around what they need. So that means we moved away from visits, hospitalizations, tests, and to the actual outcomes that matter to patients. So said another way, we need to improve value to patients. And value is either that the health outcomes that matter to patients are better, and you can either do that by improving those outcomes without raising costs, or lower costs without compromising outcomes. So let's take it to an endo aspect. There was a study done in JADA a couple of years ago that looked at patient outcomes in terms of total cost expenditure for direct pulp caps versus doing the root canal right then, and they followed these patients over 10 years. What they actually found is it was better to do the root canal initially because when you add on the extra cost, pain, extra visits for a failing direct pulp cap, it was better to fix the problem in the first place by doing the root canal. Now, I still do direct pulp caps, but it's very, depending on the patient, sometimes I'm more prone to go towards a full root canal if the reason that they had it was, deep caries or other things like that. And that's because that's a value that's an outcome that matters to the patient. That X-ray I sent from the referring office in town, if you had just adjusted the bite, that's far cheaper and probably would have fixed their problem. And now they don't have to have a new crown done. Now they don't have to have the root canal done. Now they don't have to eventually, the tooth's going to crack. Every time we touch a tooth, we kind of make things worse for the outcome of that tooth. Short term, yeah, we can make it better by doing the root canal. But every time we take away more tooth structure, we're weakening it and speeding up the process at which it needs a crown, a root canal, an extraction, etc. So what does that mean in endo, and what are patient-centered outcomes that they actually care about? Sorry, my dog's here. That was that sneeze. That wasn't me.
Right.
So you've seen him before. He's actually, that's a funny inflammation story. He actually popped a disc and was limping, and he's like a corgi mix, so he's very funny looking. And the treatment for it, speaking of value-centered outcomes, instead of moving straight to surgery, now what they do is they have you keep him in a crate for about 23 and a half hours a day. And that lack of movement actually forms scar tissue over the bulging disc. And you do this for 4 weeks, and he has like a tiny, he can't quite pee correctly. He kind of gets a little wobbly when he lifts his leg, but otherwise he's totally good to go. And that was a extremely low cost. He doesn't have the issues with undergoing the surgery, and the outcome is far, far better. So we're doing this in other realms of medicine. We just have kind of a little bit ways to go to catch up as far as endo. So what are patient-centered outcomes? Can I actually function on this thing? Does it hurt? How long will it last? Do a fun experiment today. Though when you guys go see your patients this afternoon and for the first years next week, when you're getting that patient numb right before, just to really get the heart rate going on them, ask them, hey, how long do you think this will last? Because I'm sure the response is going to be, how long do you think this will last? You are the doctor. But if you ask patients, they'll probably say the rest of my life. And that's reasonable to expect. How much tooth is left? The patient-centered outcome also has to be the referring dentist-centered outcome. So the patient that I showed you earlier with the truss access and it was all prepped, well, from a referring dentist standpoint, that's a very easy crown prep. I made their lives a lot easier. And we'll talk about the next week or next month. I'm going to do referral relationships and stuff like that. So that's something you have to have in the back of your mind as well. And then we also want to talk about aesthetics. There is a dental school about 45 minutes north of you where I taught when I was in residency. And the process department there believed, doctor-centered outcome, that every root canal treated tooth needed to have a metal post in it no matter what. Why? Because that's what they were taught. You do a root canal, you need to put a post inside it. Well, I can tell you, I have repaired a lot of post perforations. We had a lot of issues with posts being placed in the wrong. It was bad. Okay, so that's bad for the patient-centered outcome. And do you know what happens when you put a big old fat metal post right on down number 9? It's going to turn gray. Is that something that's great for a patient when you could do a fiber post or not a post at all? Things to think about. Oops, sorry, hit the wrong button. I don't know why Keynote does this. We have to go back through all of them. It's very annoying. So, okay. And that's the thing to remember here is that we don't work on dogs. We work on people that do things like win the Darwin Award. For the one right here is a guy who stabbed himself wearing his bulletproof vest trying to see if the bulletproof vest would stop a knife. It didn't. These are the patients that we work on. And so every time you're working on a patient, you need to think of them saying this that weekend. You don't know, even that sweet old lady is going to do something to, kind of mess up your work. And so what I recommend is that every time you come in and look at a tooth, plan for failure. Look at it and say, what is the most likely way that this tooth is going to fail? Is it going to crack? Is it going to be occlusion? Is it going to be perio? Is it going to be caries? And then when you're in that mindset of planning for failure or revision, think about what you can do in the moment to minimize those risks. All right. The other thing that we're starting to do now, if you talk to any of the high-end prosthodontists, high-end restorative dentists, we treatment plan as though everyone is going to live to 100. Now, I know there are considerations for that, and we've seen 60-year-olds that look 100, and we've seen 60-year-olds that look 30. So you kind of have to take it based on the patient. But is it better to do a retreat on a tooth that's kind of questionable on a 70-year-old? Or tell them to take it out and do an implant? Because if it only lasts 5-10 years, did they really get that much value? And how much harder is it going to be to do an implant and extraction and graft when they're in their 80s or 90s than doing it right now when they're healthy? Kind of like when we talk about doing wisdom teeth extractions, we like to take those, or Chris, who's not here, but Chris was normally right there. And we like to take those out before they turn 20, ideally, because the bone's still soft, they heal up great. Doesn't matter if it's not hurting, they can cause problems if they're coming in sideways, and you can recover so much better when you're younger than you can when you're older. So when you're looking at this, and right now, do the root canals, focus on getting good at those skills. That's what you guys are doing. But when you get out, start to think of it as though you are treatment planning to 100, and how long is this tooth going to last if I do this root canal? All right. We're finally getting to the meat of the procedure or presentation. Oh, we're doing great on time, which is the causes of endo failure. There's a bunch. Well, this is all I could think of. If you can think of any more, let me know. We're going to go through all these one by one. But we're going to start off with probably the number one reason I have to do endo revisions or retreats, which is untreated anatomy. And that can be anything, but let's be real, it's MB2. I draw this daily. No joke. I have a cone beam, slice it like this, show them where the roots are for the patient experience. See how this one's centered, this one's centered. Do you see how this one's off to the right? That's because there's almost always a second canal and the bacteria come back and cause an infection. You can have extra canals, which is my favorite term, meaning the original dentist didn't find it. You could have a short obturation like you see on the right-hand side. You could have lateral canals. You could have a file that's broken off to not, impede your ability to get down to the bottom. There's lots of reasons that you have untreated anatomy, but this is by far the most common reason that we have failures and that I have to redo root canals. So does anyone want to guess what happened to this canine that I have up? Tell yourself a story. What did the original dentist do?
Ledge.
Perfect. What else? Anything else you can think of?
Separate instrument down there.
It's not actually. It's just a really poorly obturation. You can see it's like they took two cones and just shoved it in pretty much. This case, I think this canine was 20, I want to say 28 millimeters long, right around there. And guess where 25 millimeters is? It would be right here. So I'm pretty sure this was done by a dentist that didn't have extra long files. And so they shaped it to 25 and they filled it to 25 and said, well, we'll see what happens. And you see this quite a lot. I've often seen even on shorter cases where they clearly only had 21 millimeter files and left the apical area untreated because they couldn't get down it. So that I assume none of you will do because you'll just get the actual proper instruments. But I see this more often than you'd think, where the cases are obviously short by the exact amount of what their longest file was. So what do you guys think the incidence of MB2 is? You've done this lit, haven't you? Second years? Throw it out.
90?
Yeah.
90? Perfect. Okay, so yeah. I mean, I think it's up around there. This is where the literature is kind of tough because most of them are done using cone beams or studies like that. And so this was a more recent one from about a year ago. And their result was that, and pretty good numbers. They had 1,000 roots, which is great, about 2/3, 1/3 first molar, second molar. And here are the things that I pointed out. An unsatisfactory obturation was in 43% of those cases. Apical periodontitis was in 55% of teeth. There was an MB2 observed in 55% of the images, and 84% of those did not actually have fillings. So what I'm trying to tell you is the bar is so stinking low for our profession. Just find the MB2s. So I did an informal study and said, okay, I'm going to take every first molar that I did this month, and we're going to see how many of them have MB2s. So let's go through them. You want it to look like this, where you have, MBs. So there's an MB2, 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 MB2. This one actually was an MB3. So the original dentist had found MB1 and MB2. That's what you see, these two gutta-percha things right here. But that is MB3, and that's why it caused a failure, which is kind of fun. There's an MB2, 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 there's an MB2. And the case that I literally just did before coming in had an MB2. So I had 100% for this month for first molars of the incidence of MB2. Do you want to know how to pay off your student loans? Learn to find MB2. You want to get a fancy car? Learn to find MB2. You want to get a fancy house? Learn to find MB2. It is the most important skill you need to learn how to do is find that canal, learn how to do it. You have fantastic professors here. I've given lectures on it before. I'm happy to give the lecture again if you want, but this is an important skill to do because it's pretty much almost always there, except in really, really weird cases. Okay. Any questions about that? No? Second years, do you guys feel okay finding MB2s?
Yeah. Okay.
That sounded really assured.
I've got a question for you. What's your threshold for how much would you trough? Because there's sometimes you can confirm MB2 on CDCT.
Yeah.
You're troughing in the right direction, you're progressing, but you're kind of getting weirded out.
Yeah.
Rating. So it's I'm sure it's case by case, but do you have a certain protocol in doing that?
In general, I do what Hatton drilled into us, which is you got to go down through 3 millimeters. and trough kind of along the distance. So what I like to do is, I probably could just bring up the MB. If we have time at the end, I'll bring up the picture. But find the other 3 canals first. That's the most important thing, because then you can use that as from an anatomical guide to know where to go. Find MB1, find palatal, draw a line between them, and then draw almost like a comma shape. That's usually somewhere along that comma shape is where your MB2 is going to be. And I like to, if I don't know where it is, I'm usually going to start by troughing in that half aspect, like closer to the MB, start in the MB, trough, and I usually do the comma shape and go down about 3 millimeters. I'll usually start just kind of brushing it and seeing. This is one where I like to do it with no water, because the dust from the dentin will actually get stuck in the hole. And so you can, if you have an air-only Stropco tip, that's really useful, because you can just kind of dry it and the dust stays in the MB2. That's actually how I found this one. This was my case I just did. I couldn't really see it to begin with, and I started troughing kind of along in this. You can actually see it. It dropped down a little bit. Where's the post-op? Can you see it there? Not really. So the troughing isn't
regular taper diamond.
Yeah, skinny taper diamond. I use an 850-014 is the one that I use. So if you watch my YouTube videos, it's used on every single case. So that would be kind of my recommendation. Start with that. If I think it's still there, I will stop the case, put calcium hydroxide in it, get a cone beam, because the calcium hydroxide almost works like contrast then. So I can see very clearly where I am and where I need to go. And rarely you'll see like, oh, actually it joined and we're now centered and you're good to go. Most of the time though, I can see, okay, I now need to drop another 2 millimeters and I need to go more mesially or whatever it may be. So use your cone beam in this case, or in cases like that, if you cannot find it, if you're hitting a brick wall. And you'll find that it gets easier with time. With the microscopes you'll have in private practice will probably be better than what you're using right now. You'll have better lighting, you'll have better instruments. And with a really bright light and a good microscope, you can usually start to see some outline of where the pulp chamber was, kind of like the developmental grooves inside the actual root itself. When the tooth was growing, you can see where you need to go, and it almost gives you a line. It's very rare that I see cases that are a complete brick wall, completely white. You cannot find anything. And on those, you kind of have to go back to your, pathways of the pulp style axes and make a little bit more space, just because you don't know where it's going to be. So any other questions there? That was a good one. Thanks, Ron. Nope. Okay. Next reason that root canals fail is vertical root fractures. This is a hour-long lecture in itself. We all know what they look like. Sometimes you can even see them on a PA. The reason, or the main reason, and there's the nuances between cracks, split tooth, vertical root fractures. They're all over the place. If you guys care about that, I'll happily give you a lecture. But in general, the more tooth structure that's removed, so use of really big shapes, the more aggressive the occlusion is, and then location in the mouth are your most common reasons to have a vertical root fracture. Once again, if you want a lecture on that, let me know, but we all know what those look like. So this is, if you're on a Discord, every now and then you'll see this one pop out, because a lot of gurus will tell you can't see a crack on a cone beam, and I agree with them, but every now and then that one you can. I didn't even take a cone beam on that one. I was like, I'm not going to waste your money on that. That's pretty obvious. So next one will be failures in obturation, and I mean, I don't think anyone's happy with the obturation on number 9 there. And there's multiple reasons that you can have failures here. The concept of long or short, the reason I put that in quotes is one of my favorite lines is, how do you get 3 endodontists to disagree? Do you guys know this joke? Oh, it's good. Show them an x-ray and ask them, is it long, short, or right at the apex? One will say long, one will say short, one will say right at the apex. And so it's very subjective. In general, the lit has shown it is better to be slightly short than long as far as outcomes. Take that for what it will. And then there's obviously the concept of Resolon or Thermothil. I don't think you guys will see too much more Resolon cases. Have any of you seen one?
No.
No, yeah. Rohan, are you going back to New York?
Likely.
Yeah, you might see it there. It was way more prevalent on the East Coast than on the West. I've seen one my entire career. So it's just not super, super common. But Resolon was a big deal back in the day on the East Coast. So you might see more, just geographically spaced out. I see a ton of thermophil. I do a thermophil case a week. So that is super common. And the problem, Resolon had a lot of issues. Do you guys all know what I'm talking about when I say Resolon? It's okay to say no. Cool. Resolon was a material that came out in the early 2000s. And the idea was you would bond the filling material like in the root, like you would a traditional composite. So it had a special rinse you had to do to prepare the canal, almost like as you're etching it. It had a special sealant that worked kind of like a bonding agent. And then it had a special gutta percha that was impregnated with stuff. So it would almost adhere to the tooth. And when it was done well, it worked great. The problem is if there was any leakage whatsoever, it turns into this black mush that is absolutely terrible. It's very easy to retreat because it's like a soup when you get inside there, but it's really tough to get all of that out because it's so nasty. Thermophil, everyone here knows thermophil, right? That one you guys should know. Yes?
Oh, yeah.
Yeah.
All right, cool. Yeah. Second years, I assume you've retreated a few thermophil cases so far?
Oh, yeah.
Oh, yeah. Okay. Get good at that. It's out there. It's still more common than you would think. Thermophil is not a bad product. However, it's often used incorrectly. And the ideal way, did you guys have to do a thermophil case? Have you done one?
Like
Has anyone done one?
Yeah,
No?
unextracted teeth.
Okay. So how you're supposed to do it, you heat it up and you push that little thing down slowly and you do it short of the apex. So the idea is that you have this push of gutta percha that goes in front of the plastic carrier. So the gutta percha is what seals the tooth, and the plastic carrier is just kind of, well, a carrier for it. The problem is, like you see here, if you push too hard, that carrier now goes out the apex of the tooth, and plastic doesn't seal like gutta percha, and it fails. It's one of the main reasons we see this. The other thing is a lot of users will think, oh, I'm short in my, I got a ledge. I can't get down to the very bottom of the tooth. So I'll just push really hard with the thermophil and that'll fix the problem. And it doesn't. So get good at retreating those. You'll see those quite a lot. Separated instruments. When you look at the actual lid on this, really, endo instrument fracture had no adverse influence on the outcome. Really didn't make a difference here. Is it more of a doctor or process-centered outcome of needing to get them out? Probably. That's the equation. Do you want to leave it, do a nickel titanium based obturation, or should you take it out? In general, if I have a case that comes in with a fractured instrument and it's in the coronal third, I'm going to take it out. Those are pretty easy to get. You don't have to remove too much tooth structure. Get good with ultrasonics, and you can usually get those out without damaging the tooth too much. If it's at the apex or if that's the obturation, I'm leaving it. It's not, you're going to destroy that tooth. And for what? To make the x-ray look a little bit prettier? That's not a patient-centered outcome. The other problem is, if any of you want to do a study, this one will suck, but the most recent one was 2005. And of all the studies we had, only 2 made it into the systematic review because the other ones had so many errors. So this is one where we really don't know if it's good, bad, why did it break in the first case? So I would say, I told you what I do. If I can get it, I'll get it. If I can't, I'll leave it and then just do an apical if I need to. So how many of you broken a file yet?
Nah.
Yeah. Do you still have to give Hatton $5?
No.
Yeah. So we had to, every time he broke a file, you had to give him $5. And then at the end of the year, he would take everybody out with that money. And it was called, God, what was it called? You'll have to ask him what it was called and someone text me because it was something hilarious, like the failure bar crawl or something like that. Because it's Hatton, as you know. All right, recurrent decay. We do see this quite a lot. And the problem is there's really no good research on prevalence. Most of the caries studies are not great. If you have patients who come in with really bad decay, it's tough as well. The other thing I recommend is that you need to look at the entire mouth. So right now on the x-ray I have up there, that was the only tooth that had an issue. So let's take care of it, do the root canal, it's good. Think though, if every single tooth in the mouth had decay like that, and they came into your office and said, hey, I have I can spend what my dental insurance company maximum is for the year on my mouth, and I want a root canal right here. Well, what are you going to do with the rest of the teeth? Think of when you're treatment planning and saying, I mean, we can all see, yeah, that's going to need a root canal. That's pretty straightforward. And when you think about that, you need to look at the rest of the mouth and remember that there is a patient attached to that tooth. And there are times when I've actually said on teeth that we could totally save, you should probably get this extracted and focus on some more strategic teeth so that you don't have these issues and kind of use your money more wisely. And that's really the question is, what value are you providing if the case is sure, you can fix it, but if it's just going to get recurrent decay right after that, what's the point? So here's another example. What do you guys think caused failure on this case?
Decay, crown leakage.
Decay, crown leakage. There's missed anatomy. It's C-shaped. It's thermophil inside there. There's loose carriers. So I ended up retreating this one. That's what it looked like when it was all said and done. But you can see there was a lot of untreated anatomy between those two, especially in that C kind of that goes between it. So this is something you'll be seeing more and more often. And you kind of want to talk with them about why did they get the decay in the first place? Talk to your general dentist, get on some fluoride, talk about diet, that sort of thing.
How'd you operate?
That was cones. That was cones. Yeah, that large. The freaking distal was a 50. It was a F5 because it's so huge. So I don't like to squirt cases that large. So there's a couple of videos on YouTube that I've posted on obturating larger shapes. Actually, I have one coming out on operating smaller shapes too. So, but in general, if it's that large, or if there's a large infection, this was a 2-step. If there's still a large infection in there, you don't have that back pressure when you're injecting and doing the squirt technique, and therefore you're more likely to get a bunch of crap shoved out the apex of the tooth. And I know with a cone, I can be more precise in where it stops and where I sear it off. Make sense?
Sounds good.
Anyone tried the squirt technique yet? No?
I don't think we're allowed.
You only get in trouble if you mess it up. I didn't tell you that. All right. When you guys graduate, you can come out to Reno and we'll show you how to do it. All right. Resorption. In general, more what I see, I don't see resorption happening a lot on teeth that have already had root canals, unless there's something weird, like wisdom tooth coming in sideways and causing resorption there, or some weird trauma. And when you think about resorption, this is another hour-long lecture in itself, is dealing with resorption and how to triage which way you want to do. You have the extracanal invasive resorption, which is our most common that I see, ankylosis from trauma, and then external apical resorption from, ortho, from movement. And you're not going to see a lot of cases where a completely normal tooth then gets resorption after, because you remove the blood supply inside the tooth, and the chance of it having issues internally is now 0. So it would just be external. And I really don't see it often where a front tooth that's had a root canal ends up having ECIR after. However, what I do see a lot of, and if we think of this tooth right here, how is this tooth going to fail? Shout it out.
Fracture.
Say fracture. Perfect. So fracture, probably, snap off failure. What's the other way it's going to fail? So this is a ECR lesion. It stops right at the bone with a little bit of tunneling. It's going to fail if I don't get out all the resorption. The resorption is going to come back. And when I'm thinking about this, I can lessen the risk of that snap off by keeping my access small and putting a post inside there to help transmit some of the forces more apically into the periodontium rather than right at the cervical area of the tooth. And I can make sure that we spend extra time to get all of the resorption out to minimize that risk. But that's what I want you guys to start thinking about, is when you're looking at teeth, how is this going to fail? And what can I do as a provider to minimize that risk? All right. Extraradicular bacteria or cyst. I put these two together because they're kind of, together. When we look at the studies, and there he is, Rikuchi, right there. I just saw that. Didn't even do that on purpose. Radicular cyst is your most prevalent intraosseous jaw lesion, so they do exist. They happen more often than you'd think. You really don't see a lot of extraradicular biofilms. Most of the time, the bacteria stay inside the tooth. They don't get to the outside. So it's not a super, super common thing. This is more of a histological-centered outcome if there is bacteria inside there, hence Rikuchi being on there. And really, this is where it comes down to, do you want to do a surgery or do you want to try to do orthograde retreatment first? And that is very much a doctor and patient conversation. You need to talk about risks with both of those. You need to talk about, is it better to retreat first and then possibly do a surgery? Well, you probably set the tooth up for the best success there, but that's multiple appointments plus multiple costs associated with it. If you do decide to write it off, then that's a lost cost to you. If you decide to charge the patient, how are you going to charge them? This is where you kind of have to think about it in a patient-oriented mindset. One other story from that office that I used to work at, if after a year the patient came back and they still had a spot on the x-ray, they would go in free of charge and would flap the tooth and clean out what was ever inside there and put a bone graft to make the x-ray look prettier. And he told me this with glee on his, like, this was the coolest thing that he was doing. And I was just appalled because from a patient-centered standpoint, that probably was going to heal. It just needed more time. It wasn't causing him any pain. Now they have scarring plus all the postoperative issues with an apico. Plus, you just took a dead person's bone and shoved it into someone because you wanted to make an x-ray look better. So I try to minimize the surgeries that I do because they are more complicated. There are more complications for patients with them, but I still do quite a fair amount. So learn how to do your apicos. I posted a video. We did the video last year, right, on apicos?
Yes.
Yes. So first years, it's on YouTube. I recorded that one for you if you want to watch that. Otherwise, I'm happy to give the lecture again. Perforations. How many perf to tooth? Come on. There we go. That's right. We all do it. And what's the thing with perforations? Repair them immediately. Your newer materials are going to be superior to MTA for repair, but MTA still is the gold standard, works fantastic. I use BC putty or root repair material. That's really hard to say for all of my cases, just because it's easier to have one and it works great for apicos and for cases like I need it when I need it. Smaller is better. Immediately repair it. That's going to be your two best ways to make sure you have a better success, and where location is important. So on this case, you see right here, it was a referral where a general dentist had ledged himself out and could not get past it. So sent it to me. He was about 4 millimeters short of where he should be. I was able to bypass it, but the way I bypassed it was creating. That's not a lateral canal. That would be the initial canal. And that straight part next to it would be my rotary file that went around it. And I'm not worried about this case at all. We see this happen all the time. I think half of the lateral canals that we see are actually just exits out the side of the tooth, and the endodontist created a straight line through it. So you really don't have issues with that. Sometimes if I'm worried about it, what I will do is switch to using something like a bioceramic sealer, so that not only are we protecting the tooth by repairing it immediately, the bioceramic, if there is any inflammation, that will lessen the risk compared to something like AH+. So any questions on perforations? It happens. Repair them, own up to them, tell the patient. Of all the ones I've had, I think maybe one's failed. It's as long as you repair it right away, keep it small, realize it, own up to it, it really isn't a big deal. Immunotherapy, this goes back to this line that we showed earlier. You can have patients who have spots on the x-ray that have been there for 20 years and no pain, no issues whatsoever, and they are going in and they have some form of cancer and need to have radiation or chemo or whatever it may be, and those blow up. I am very, very conservative when it comes to retreating asymptomatic cases with findings on them. This is the one time where I do say, yeah, we probably should retreat this just to minimize that risk, because think of the risk. The risk now is, not only are you completely immunocompromised, you now have a massive infection in your face, and I have to somehow do a root canal on you. So that would be the one case to consider there if you're ever doing cancer clearances or things like that. In general, most of the oncologists are going to want them to be completely free of any infections, which means any black spots on a cone beam. New restorations and occlusion. This is probably the most, literally the other patient I saw this morning was a case where I had done a root canal. She got a new crown and it was just being beat to shit by the opposing tooth and the tooth hurt. So that's this we see all the stinking time. New restorations are more than likely going to be made out of harder materials. We don't see a lot of people using gold. We don't see a lot of PFMs anymore. We mostly see lithium disilicate or Emax crowns, and we see a lot of zirconia. And in this case right here, those massive cusps on the maxillary teeth were causing pain on the mandibular teeth. And what causes this? Most of the time, if you've ever used a CAD-CAM machine, when they take the bite, it's a static bite. So it's really good at knowing the up and down forces, those straight occlusal line forces. It's great at figuring those out. We don't take a moving bite like you would with an articulator, though. And when you just say auto occlusion, what it does is you take does everyone know the difference between the working and non-working cusps?
Yeah.
The buccal of the upper and the lingual of the lower are the non-working cusps. And that means, so if these are the maxillary teeth, these are mandibular teeth, this area here should be touching and working. This area, if it's too large, will cause fremitus or issues when you go into lateral translation. And what happens is the machine's really good at figuring out this part, and then it just takes those cusps on either side and cranks them up to 1,000. I've seen crowns that have like a lower crown that has completely normal buccal cusps, and then the lingual cusps are like up here. It's that bad. And the solution is just get them down to the same level. So this is what I do all day long. Remember that the bowl, the buccal of the upper, the lingual of the lower, that will take you so far, and you can fix a lot of people's pain immediately. It's amazing how they get used to it, and they're like, "Oh, I'm totally fine." And then you go and do that adjustment, and they're like, "Oh my God, I feel 1,000 times better." This is literally something I do all day long. You'll see plenty of lectures on this. I talk about this all the time. And a lot of this can also go with that inflammation. When you have a patient on the opposite side now, on the far right-hand side, that's a hyperinflamer, and you take and prep a crown and put a big old zirconia with bunch of interferences in there, you're going to have a ton of pain. So I think we have, okay, I have time for a quick story about my brother. I don't think you guys have heard this. So, and he told me I can tell this story. He was in residency, wasn't sleeping. He's a veterinarian, and he broke number 2. Never had a restoration on it whatsoever. Split the tooth. Goes to see the dentist, our family dentist. He does a crown on top of there. And I told him, hey, if you start to have really bad cold sensitivity or whatever, let me know. Now, he was going to, he went to vet school at UC Davis, so about 2.5 hours from me. And he was going to plan on come up for a weekend to hang out with me, and we were going to go, golfing and fun stuff. And he calls me like the day before, like, man, this tooth is killing me. So, okay. Only root canal I've done in shorts and flip-flops. Come in on a Saturday, take care of his tooth. Now, I was taught, this is the Kakahashi thing, that you need for there to be a way for bacteria to get inside the tooth. So I'm looking at the microscope. I've already accessed it. And when I access, I see a completely normal, healthy pulp. Looks as it should be. There's no bleeding. There's no infection. Nothing wrong with it. And by this way, though, I've drilled a hole in the tooth. So we're doing the root canal. And then I get everything clean. And I look around the outside. My dentist did a beautiful prep on there. There's no cracks left in this tooth. So this was, I think, 2015. And this is what started me down this crazy journey of what the hell is going on with these patients. And what it was is Craig was on the right side. He wasn't sleeping. He was clenching like crazy. He actually broke 2 night guards that year as well from clenching so hard. He split them in half. And that tooth back there, number 2, think about when you use scissors, the fulcrum is back here. You're going to create a lot more force on that tooth. And so it is the most common tooth to split. And then fast forward about 2 years later. By now, I've done a lot of the research and kind of looked into this sort of thing. And he splits number 12, which is the second most common tooth to split. Your first one is your upper seconds. The second most common is your upper first bis. And he splits that one. And this time, I talked to the general dentist and said, hey, can you now give him an injection of dexamethasone and a round of oral steroids as well? Because I'm seeing him as this hyperinflamer, and we need to turn that down. And I'm happy to announce he still has no root canal on that tooth, 8 years later. So you got to think about what your patient is. As far as the conclusions for failures and outcomes, you want to think about your patient or your value-centered outcome. Right now, yes, the reason we love those prescriptive ones is we can say, oh, Rohan, did you take it to this size? All right, ergo, you get an A. Johnny, you get a B. Sarah, you get a C. Sorry. And when you're looking at these, when you're out in the real world, no one's grading you. They're looking at it and saying, oh, did you get down to, everyone has their own, metrics, but really who you're serving is the patient. When you look at every single tooth, I want you to think, how is this going to fail and how can I prevent that or make it better? Untreated anatomy and occlusion are going to be your two most common causes of patient-centered failure, which is you have infection, you can't chew on the tooth, things like that. And for the love of God, learn to find MB2 because it will make your life so much better. So that is all I have for today. What question? We have actually a few minutes for questions, which is good. I timed it out that should have been about 40 minutes. So I added on Craig's story. So what questions do y'all have? Sarah, did that answer? You were the one who came up with this topic.
Yeah, no, it's great. Thank you.
Is there any aspect you want me to dive deeper into? Like crack
I
teeth?
look for middle mesials.
You look for how do I look for middle mesials?
Yeah.
Oh yeah, great. So do you know the incidence of middle mesials?
Like what, 10%?
It depends on age. That's what it really depends on. If you look at like 18-year-olds, it's up at like 25%. And if you look at 80-year-olds, it's down at 1%. And all they are is, you think of how broad that root will be. As the tooth grows and starts to calcify, eventually that middle mesial just completely calcifies out and it's gone. So look for it more on kids. Look for it more on, 18 to 30-year-olds is where you're most likely to find them. Just as we do with MB2s, find your two, MB, ML, and then literally just trough between them. That's all you got to do.
How far down are you going?
I'm going to do it. So I don't trough for mid-mesials on every case, mostly because I see an older population, so you don't really, you're not seeing it as much. However, if I've cleaned everything out and the MB looks like this and the ML looks, perfectly circular and there's nothing going in between there and it's a brick wall, I'm not going to trough. If they look almost like commas and they come into the middle, then I am going to trough. And I generally go down, once again, about 2 to 3 millimeters. And if the MB2s are really annoying in maxillary molars because when they start, they will often do like a crazy S-curve and then eventually go straight. Mid-mesials are just straight. So if you're going to find them, you will find them right away. And you'll know pretty much immediately. So the other thing I like to do with mid-mesials is I'll usually take like an 8C file or something like that to poke it. And if I get a stick, what I'm going to then do is take a rotary file and go down it. And the number of times it sticks and then just drops right into a canal, it's almost 90%. So very rarely do I actually see true the mid-mesials all separate all the way down to the very bottom, but it's still worth going in and looking at and trying to find. Have you had a couple cases that have been funky?
A few middle mesials here and there.
Yeah, they're more common than you think.
Yeah.
And one other thing to remember is sometimes they'll just stop. You would expect that the working length is going to be the same as your MB or ML because they're all right next to each other. But the number of times where you get going, you clean them out, and you're like, that's a 10 millimeters, and I'm hitting a brick wall. Sometimes they just stop. Sometimes that's where they'll take like a hard right turn into one of the other canals. So take the time and try to find it and try to get patent. But it's one of those cases where if I'm not patent on a mid-mesial, I'm still going to finish the case because the chance of it failing because of that is so stinking low versus the chance of me troughing down and trying to get patent and making my own canal and then causing a perforation or predisposing the tooth to a fracture, much, much, much higher.
Got it.
Great question. What else? Awesome. All right. Well, first years, good luck next week. That's super exciting. You all have my phone number if you have any questions or anything. I'm going to go over like referral relationships and how to create great experiences for patients next time. But the whole point of these is to talk about whatever off topics you guys need help with. So if you have something that comes up, just send me a email or text, and I will happily do it for you. So
Thank you, Doc.
Thank
cool.
you.
All right, everyone, have a good long weekend.
You too.
Bye.